So we're going to start this webinar now, and it's the problem, precision, and premium webinar. It's probably thank you to IIRSI and thank you to Alcon for doing this, for keeping us all alive and kicking even during these times of lockdown and so much of disturbance with the COVID situation across the world. We're seeing so much of so many industries go up and down, so much of disruption in our own industry, which is unheard of, and we have all not been so jobless across for a long time, to be honest. And I think the people on this panel are pretty much the most experienced, the most hardworking, and the most not resilient people. Yet COVID has actually disturbed all of us in many ways. But having said that, let's get on with the program. And I think I wanted to first introduce my co-moderator for the evening and morning for Neda and the time zones where they are, for probably late night for where Noel is from, Australia. But yeah, I'm very happy to say that, thank you all for saying yes, first of all. But my co-moderator for the evening, Bill Trattler, is a refractive corneal cataract surgeon at the Center for Excellence in Eye Care. He holds top positions at most of the big meetings, the ASCRS, the AO, and most importantly for me, I think he's one of the best people I know, and has definitely helped me in every stage of my life personally, as well as professionally. I think his wife Jen definitely believes that, and so do I. He's probably named as one of the most well-dressed and handsome ophthalmologists across the world. This he had me say this, so just for okay, but a few words from you, Bill, and then I'll introduce the panelists.
Of course, Ashvin, first of all, you've become a master at organizing these incredible educational virtual webinars. And every one I've attended that you've developed has been so educational, interactive, and has really made a big difference in my practice. And I really just love learning from so many great colleagues. And to think 5 years ago, you'd never be able to learn on a Saturday morning, or for you, maybe Saturday evening, from people around the world and actually see them like we're doing right now. It's just incredible. It's not just that, it's the topics that are being presented. We're learning so much, and it just allows us to take better care of our patients. So Ashvin, thank you for organizing this, and speakers and panelists, thank you for your great participation today in your presentations.
Thank you, Bill, for those words. I wanted to introduce the panelists first before we go on to the speakers, and I think Bill will do that as they go along with their talks. But Mahipal sir, I think, has been such a pioneer in this field of ophthalmology. The words cannot explain what he's done. He's currently the president of the AIOS, that's All India Ophthalmic, and he's also the chairman for Center of Sight. And thank you for being here, Mahipal sir, for gracing us with your thing. And I know that you will be going on and off at times, but as much as time as we can get from you, I will be happy to have you here. Next up, we have Dr. Rohit Prakash. Apart from his practice with his son in Tushya in Amritsar, I think he holds one of the most special meetings of IIRSI in Amritsar. And I think everybody, at least the ones who've attended that meeting, will definitely vouch for that meeting in terms of the quality and the presentations of what he does with that meeting. Thank you, sir, for being here. And Dr. Jeewan, I think there's words again cannot take what he's done for the field. Not just that, he's at the All India Institute, which is probably the busiest place across the world in terms of ophthalmology. Right now, maybe seeing a bit of 2 days of lockdown for its own reasons, but he has personally won Padma Shri for his work in ophthalmology, and I think that's highly reputed. Padma Shri is bestowed upon by the government of India itself. And last but not the least, panelists, we have Partha Biswas, who's the chairman scientific committee of AIOS right now, and runs a wonderful practice in Kolkata, and is a dear friend to many of us, especially me. So thank you so much for being here. Thank you so much. Up to you, Bill. Take it off.
Of course. Well, I think we should kick it off. We have so many great talks today, and our first speaker is Noel Alpins, and I know many of you know him personally. Many of you also just have learned so much from him. He's a professor and really a pioneer in the field of cataract refractive surgery really with just really leading the way for the surgical management of astigmatism. Dr. Alpins is a clinical professor at the University of Melbourne. He's on many editorial boards and he speaks at so many international conferences around the world. I've had the pleasure of listening to him many times, and I'm super excited, and I'm sure we are all excited to hear him today. Thank you, Noel.
Oh, thanks so much, Bill. And I do appreciate the invitation, and thank you for that very kind introduction. So what's important in cataract surgery in particular is when you want to correct astigmatism at the same time, of course, the toric implant is the key element to this. And what I'm going to speak about today is not only the toric implant being how to calculate the magnitude using total corneal power, not just anterior corneal power, how to manage when you do get a refractive surprise, and how vector analysis can help you determine where the surgery has gone wrong or where you can improve on it, and then a group analysis using a calculator on the ISRS website to be able to look at as many patients as you might wish. So looking at the preoperative parameters, and it's really the anterior corneal power, either SIMK or manual keratometry or core-T anterior, which is used for the formula to determine the actual spherical power of the implant. But I think if you want to get more accuracy in the astigmatic part of the toric implant power, you should go to total corneal power, not just using an extrapolated or estimated power by a formula from the anterior, but actually the measured total corneal power, either from one of the tomographers, or what I use is core-T total, which is taken from the eye sort that is interfaced with tomographers. So looking at this particular case, you can see that the anterior corneal power is about 2.8 diopters in astigmatism, but actually when you look at total corneal power, it's only 2.35. So the numbers are different and they're not interchangeable. So total corneal power includes the posterior cornea, which is the most important component to increase the accuracy. So when you bring the actual phaco incision into it, which is, let's say, a half a diopter of flattening, the 2.35 in the astigmatism of the total corneal power, actually you only need to correct 1.85 diopters when you're looking at the incision being placed on the steep meridian here, which is at 75 degrees in this particular case. So that comes down to the IOL power at the corneal plane of 1.70, using a power of the implant at the implant plane of 2.25, which is over here as part of the implant, and spherical equivalent being 30. So you can calculate from that, or this is the Assort calculator, which is available for free for all to use at www.assort.com for free, and also for ISRS members, also for free on the ISRS website. And so the calculation comes out to how to choose what power implant. You can determine by the target refraction, both the sphere and the cylinder. So there hasn't been an axis change here, and the magnitude is low. So this is the implant of choice without having any axis flip at all. So moving on to the result, if you find yourself left over with some astigmatism in the manifest refractive cylinder, in this case, minus 1.25 diopter cylinder, once it's more than a diopter, it's going to be more than the patient can tolerate. You want to really determine how are you going to work out to maybe you can adjust this implant in its position. And so just doing a calculation using the refractive surprise calculator, also a free application on the Assort website and the ISRS website, you can determine that if you actually rotate that implant in a clockwise sense by 18 degrees, you're going to reduce the implant, you're going to reduce the astigmatism left over from 1.25 down to 0.4. And that's a very worthwhile adjustment. Once you get it down to less than half a diopter, the patient is going to find that very acceptable, and their vision with a refraction like that is going to be an excellent visual result. And here's where the vector analysis can help you, because you can see, well, what might have gone wrong here? We can see The angle of error is 15 degrees, which is very similar to the amount you need to rotation, which are not always exactly the same, but they're close. And you've got here a magnitude of error. In other words, the implant is probably overpowered by about half a diopter because the correction index is 1.26, 1 being the preferred number. And that's really that relationship between the SIA and the TIA. You can see you actually achieved more than you wanted to, and that's why this implant is slightly overcorrected. So that's looking at a single case. If you want to actually look at as many cases in a group analysis calculator, so on the ISRS website, and this is free to ISRS members, you can do a refractive analysis, which is like a laser analysis from post-op to pre-op, doing the vector analysis of seeing how it performed. If you're doing corneal surgery and incisional surgery, you can do a cornea versus cornea analysis. But a toric implant analysis is a little bit different because you need to do a hybrid analysis. And what I mean by that is you're going to compare the post-operative refractive cylinder to the pre-operative corneal astigmatism. So it's hybrid, it's a mixed analysis. So looking at this analysis, this toric IOL hybrid analysis, we have here 43 eyes, for example, and you can see on the bottom two screens, the bottom two graphs, the first one being showing the regression analysis of just the SIA versus the TIA, getting a line showing that it's pretty close to 1. And then over here on the right-hand side, you can see the angle of error where about 40% of eyes were plus or minus 5 degrees, but there were some lying outside that. And as Daniel Tegnoto showed in his 2018 paper, really you don't really need to worry about rotation unless it makes a significant difference and it's more than 10 degrees off axis when you start thinking about that. So looking at the vectorial analysis of the whole group, you've got the surgically induced astigmatism vector, the SIA, you've got the TIA, the target-induced astigmatism vector, you've got the difference vector, which is really like the prediction error, how much are you actually off your target, and then the correction index, and looking at the mean of this, it comes up with a figure of 1.0, which shows that overall you're getting a pretty good average of 1. You know, some are a little bit more and some are a little bit less. So in summary, I think you need to know your toric IOL calculator and its own capabilities. But I think you want to look for a calculator like the Assault one that we have for free for you to use, which actually is able to give you the total corneal power as a separate entry to the anterior corneal power. You still need the anterior corneal power for the spherical calculations, but the total corneal power gives you a better calculation for the astigmatic power. And not just using an estimation or a calculation that's estimated, but you actually want to use the measured total corneal power, which you can take straight off your tomographer, any one of the 3 major ones, or you can use Core T Total, which interfaces with these 3 major tomographers. So for toric IOL procedures, require this hybrid analysis, which is post-op refractive cylinder versus pre-operative corneal astigmatism. And this post-op versus pre-op corneal astigmatism gives you that vectorial analysis. Has the implant overcorrected or undercorrected? How much is it overcorrected by the magnitude of error? And what's the angle of error? And how much can you rotate this using the refractive surprise calculator that we have on the ISRS website and the assort.com website to be able to help you solve those problems when the result isn't quite as you expected, which might happen in 3 to 5% of cases, like in refractive surgery. You might need to do an adjustment. Thank you.
Perfect.
Wonderful, Noel. That was just a spectacular talk, and you're so educational and really help us really understand astigmatism and how to really plan for our IOLs. We already got a couple of questions, but we're going to save those for a little bit later because we're going to jump to our next speaker, Dr. Neda Shamie. So Neda, we're so excited to have you. As everyone knows, Dr. Shamie is a really well-known LASIK, cataract, refractive, and also corneal surgeon. Just a spectacular person overall, great speaker. Many of you may know her in the United States. She's actually on the commercial for one of the for Restasis, so I actually get to see her on TV every once in a while when those ads run. But she's just an expert in dry eye as well, and she's now a partner at the Maloney Shamie Vision Institute in Los Angeles. Was the medical director of the Doheny Eye Institute in Beverly Hills in the past, and she's just a fantastic speaker, great educator. We're really excited to have you, Neda, to speak today.
Thank you so much, Bill. Thank you, Ashvin, for inviting me. It's quite an honor to be among these incredible international leaders in ophthalmology, and I really am humbled being here. If I stumble on my talk, don't mind me. It's 6 a.m. here in Los Angeles, so bear with me here. Let me share my screen. Can you all see it?
Yep.
All right, fantastic. Again, thank you so much for having me. The talk that's listed on, let me actually move this out of the way. The talk that's listed, it was a different title, and truthfully, when I started putting this talk together, it dawned on me that I think what's more unique about keratoconus and thinking about addressing keratoconus and visual rehabilitation in these patients is all the different types of patients that come in. And the other reason I changed the topic that I'm talking about is because during the COVID time, I had to convert, as we did most of us, to virtual consultations. And it really kind of forced me to focus on the history taking and the art of medicine. When I was evaluating these patients with history of keratoconus, patients I had never seen before, I really had to focus on their history to be able to make an assessment before they came in. And it was kind of a fun exercise to see how much I was able to do before actually seeing the patients. So we'll talk about keratoconus when one size doesn't fit all. Let me see. All right, there you go. All right, so as we know, keratoconus is a progressive condition in many patients, and it is a kind of a spectrum of disease where patients can fall anywhere on the spectrum. And when they arrive at our office for consultation, we may catch them at any point in that spectrum. We may likely have to decide if there's been progression of disease. We would need to evaluate if there is a surgical treatment for their visual complaints, or can this be done in a non-surgical way. And the other concern is always, do we need to shift the corneal shape or change it to address their visual complaints? So really, I think it comes down to chief complaints. Many times patients with keratoconus are just told to come in for corneal evaluation, when in fact, much of their visual complaints can be addressed with a non-surgical way. So most of my talk is actually just case by case and discussing how a case may be addressed uniquely. Obviously, I'm humbled to be among world experts on this topic, so I apologize if this is below level of interest, but bear with me for the next 10 minutes. So here's an interesting case, actually, 25-year-old seeking laser vision correction for spectacle independence. That's a 6 a.m. Issue there. As you can see, very high myope and a high level of astigmatism. There's a question of asymmetry on the corneal topography. 25-year-old, you would wonder if they are if they are keratoconic, if it would be progressive. But one thing that was important in the history, they were able to show me the prescription for their glasses 2 years ago on virtual consultation, and in fact had not changed. And this patient has been happy with their spectacle vision, but would like independence, and really no family history or other risk factors. So they finally came in, and indeed the corneal topography was somewhat questionable, and the pachymetry map also showed thinner corneas and some asymmetry. So this patient may very well have form fruste. Of course, with that level of refractive error, would not be a candidate for laser vision correction, but we offered toric ICL and monitoring for keratoconus in this patient, thinking that they may actually be keratoconus suspect or form fruste. And in fact, the results have been fantastic. Here's another case referred for keratoconus consult. This is different. Actually came in with a diagnosis of keratoconus and advised collagen cross-linking before they came to see me. The patient, though, reported vision was good without glasses even, but quote unquote, the left eye has always been weaker. And sometimes the eyes cross if they're not wearing their glasses. And as you can see, there's significant anisometropia. There's also significant difference in the corneal astigmatism and refractive astigmatism. This is a patient who doesn't have keratoconus based on the measurements we did in our office. Very symmetric astigmatism on corneal topography, very symmetric anterior segment OCT pachymetry map on this patient. And their prescription has also been very stable for the last 3 years. So this is a patient who has just normal symmetric astigmatism, anisometropia, and amblyopia in the left eye. And truthfully, the patient was very happy. And this is where I think history is more important than our clinical findings. We don't treat diagnoses, we treat patients' complaints. We offered a refractive lens exchange with a toric lens in this patient, but encouraged them to go about their life without any intervention, given that they were happy. So here's more kind of towards keratoconus, 30-year-old with keratoconus and progressive change in vision over the last 3 years in their better eye. Here's a change from 2015 to 2018. Was able to wear RGPs, but now is not able to tolerate them. Again, much of this history without the topography was taken from virtual consultation, and patient was an avid eye rubber. And indeed, I actually was able to, during our virtual conversation, talk about progressive keratoconus without really having much more diagnostic values on this patient, and advise collagen cross-linking to stabilize the keratoconus and then address the visual complaints after stabilization, or even potentially with. Many of the panelists and speakers on this wonderful webinar actually do PRK together with collagen cross-linking. In this case, I went ahead and performed collagen cross-linking, and after 1 year, there was significant improvement in the better eye, the right eye, with vision actually correctable with spectacles to 20/20. The worse eye was not as easily correctable, but nevertheless was stabilized and improved, and the patient was fitted with rigid gas permeable, actually scleral lens in this case. This case, again, an older keratoconic. So what we know is that with older patients, there's some slow progression. I don't believe, and I think Dr. Trattler has spoken about this a lot, I don't believe that it stops progressing. I think it may slow down. But in this case, the patient was referred for corneal transplant in the left eye because the patient had been reporting worsening vision, but said that prior to 3 years ago, the vision had been quite good with glasses and only started to worsen over the last 3 years. So in looking at this patient, the optometrist said that sclerals did not help with the vision and felt that a corneal transplant would be the right approach. As you can see, this is the MR in the office. The vision was only correctable to 20/50 with manifest refraction. But when you take the right history, it actually helps guide the treatment in most of our patients. The glasses from 3 years ago were had the same cylinder with much better vision. So this points at a different reason for the patient's loss of vision. And in fact, the patient was found to have visually significant PSC cataract, and a toric lens was offered to this patient because the central 3 millimeter of the corneal topography showed very symmetric bow tie astigmatism. And this is key in these patients with keratoconus, that if that central 3 millimeters shows you very symmetric astigmatism, and especially if the patient reports that with glasses they were able to obtain excellent vision, typically toric lens is a fantastic option in these patients. And in fact, this patient was able to have 20/25 vision without correction. And this is my last case. So 48-year-old with keratoconus. Now this one is quite advanced, intolerant of scleral or RGPs due to chronic GPC and significant thinning of the cornea. And at the apex was actually less than 300 microns. And this is their best corrected visual acuity with an RGP, not that much better, but they were unable to tolerate the RGP. And indeed, again, severe keratoconus, no scarring, and no break in the decimase. And so the plan for this patient was to perform deep anterior lamellar keratoplasty using the big bubble technique. And I tend to really prefer a running suture, a 24-bite running suture in these types of patients with a deep anterior lamellar keratoplasty, and actually using the femtosecond laser for a zigzag incision. And in doing all of these steps and adjusting the suture early on, I'm able to get really fantastic refractive outcomes and contour of the cornea. And in this case, after removing the sutures at the 12-month mark, the patient had a very symmetric astigmatism of less than 2 diopters. And I was able then to perform femtosecond cataract surgery with a toric lens implant and offer the patient uncorrected visual acuity of 20/25. So these are different versions of keratoconus, of patients in spectrum of keratoconus that were handled differently. I think the key comes again down to addressing the patient's chief complaint and not their diagnoses, and really think about treatment goals when you're addressing these patients. Is it stopping the progression of the keratoconus? Is it wanting to change the shape of the cornea? And consider lens-based options to optimize the patient's vision. And lens-based could be in the form of an implantable contact lens, a refractive lens exchange, or a toric lens in those cases that have very symmetric central astigmatism. And also, I now am, with all the advances in the field and experts like yourself who have led us this way, corneal transplant has become the last resort in many of these patients. Thank you so much. And this is my family who's fast asleep in the other room. And I really thank you again, Ashvin and Bill, for inviting me to join this wonderful webinar.
Neda, could you just stop the share? It's the orange button on top. Yeah.
Yes.
Perfect.
I mean, Ashvin, what do you think? That was a spectacular talk.
I think that was great. It gave such a whole holistic view of the whole keratoconus picture, which takes you from the mild cases to the moderate and the advanced ones. So gives you a spectrum of what exactly someone would do in their practice and probably should do, or probably refer them to Neda and then she'll take care of it.
Thank
Absolutely.
you.
It was beautiful. And we got so many great questions for both your talk and Dr. Alpin's talk. So please, everyone, ask more questions, but we're going to have a great Q&A session coming up. So now we're going to move on to our next speaker, Dr. Stephen Slade. Dr. Slade is, as everyone knows, a corneal cataract and refractive surgeon in Houston, Texas. And he's, I mean, when I was in training, he actually taught my professors, not that he was really young, but he actually taught my professors how to perform LASIK. So he's been at a cutting edge from for decades. He's just an amazing surgeon, amazing doctor. He runs one of my favorite meetings as well in the year, called the ACOS ASPA meeting, which is just a fantastic meeting in Colorado every February. We're really excited for his talk today. Thank you, Steve, for presenting.
Oh, great. Thanks, Bill. Ashvin, I've got, can't start my video because the host has stopped it.
Okay, wait.
Ravi,
you just have that.
If you would just flick that on.
Yep, we'll do
one of the worst things about this whole pandemic is that it
try now.
Wrecked. There we go. Great. One of the worst things about this whole pandemic was that it wrecked my trip to India for Ashvin and Amar's meeting. We had my whole family ready to go, and we really, really regret that. That hurt. But thank you very much for including me on this morning. Thank you, Bill. Thank you, Ashvin, and everybody who showed up all around the world at different times. I really do appreciate it to be included in such a great meeting. So let's go on and start.
Just open the application and then share the screen.
There. That should work. Yes? Okay, perfect. Okay, so my topic is lens selection in post-refractive and complex corneas. And we're a little bit of a setup here in Houston. I think RK was so prevalent here. We were doing more numbers than any place else really in the United States. And then we got a hold of LASIK early. So in my clinic and specializing in cornea, we get a lot of patients that wouldn't be considered your ideal patients for cataract surgery. And there's just the roadmap is very complex, but I really want to concentrate just on two things today, and that's patient selection and lens selection. Now, leaving the country the next day is always a great patient selection criteria. Hopefully, if they're going to someplace like India, then Ashvin can take care of them postoperatively, and that's wonderful. But most of the time, not only are you doing the surgery, but you're going to be taking care of these people and trying to meet their expectations. And especially with the refractive patients, their expectations are high. You at one point in time, you made them 20/20, and they didn't have to wear glasses after LASIK. So they certainly can have the highest expectations of any patients you do. Current complaints will be wearing glasses, fuzzy vision, halos, the whole thing. Surgical history, you want to know what they've had. It may limit your options later in life. And then all the things you're used to doing, dry eye exam, a really good slit lamp, the status of their retina, become even more important. Topographies, looking at their aberrations with multiple devices, keratometry, the higher order aberrations, maybe checking their aberrations with a dilated pupil and then their normal pupil. And having different devices really does help us. Dry eyes, just jump all over this, because this can wreck your entire surgery. Certainly if get them stable first, not only for the lens selection, but again, for their vision after surgery. We use lots of serum tears on our patients, and that helps. I would encourage you to look at that. So LASIK, well, most of the LASIK patients really do just quite well, and they turn into routine cataract patients. But that's kind of your myopes and your spherical myopes. It's extremely helpful to know what kind of LASIK they had, how much, were there any complications, were there re-ops? So knowing their surgical history helps. This looks great, right? I mean, it's a myope, it's less than 6 diopters. I'm not sure this adds any risk or is going to hurt your outcomes at all, really. Hyperopic LASIK, I'm actually more comfortable doing these certainly than I used to be, and I think what is out there a lot, these people also do well, but how much hyperopic LASIK have they had? How steep? Look at their negative spherical aberration that you induce. The centration is so key. The treated optical zone or the effective optical zone that you come out with for a hyperope is always smaller. Their pupils may be smaller, but so is their optical zone. So look at these people, your hyperopes, especially carefully. We like, this is a Tracy readout, ray tracing. We use it a lot. And there's a lot of sort of magic numbers that people put out there with how much coma, how much total aberration, how much negative spherical aberration they'll treat. This patient has 0.6, for example, and I hear that number a lot. But I'm not a big fan of magic numbers, limits arbitrarily sort of dogmatically stated. So remember this in the whole picture. And again, a Tracy reading. One thing that we found useful is kind of old school, and that's simply look at the Myers of the patient. In your testing, one trick that we use is we use a lot of contact lens, scleral lens over refractions. We're not really trying to fit them with a scleral lens. Of course, if they turn out liking the scleral lens, great. We may do with that for a while. But really what we're trying to do is rule out the cornea component of their visual deficit. If they have, if they come in complaining of vision and you can determine with a hard contact lens over refraction that a great deal of its cornea, you're not going to fix that with a cataract surgery. So what are you going to do? You can certainly maybe make them better, certainly maybe. You can likely make them better by taking out their cataract, all predicated on having a good retina. But the real improvement might be from the cornea. Remember, also, once you've put in a lens, if it's a toric lens, if it's a light adjustable lens, putting on a contact lens now is going to be problematic because you're going to show and let their corneal the astigmatism of the lens come through. So a lot of times you may have to tell a patient, you'll still have to wear your contact lenses after this. Radiokeratotomy. Oh, these people are coming in droves now. This was sort of the baby boomers' refractive surgery. And there were just a lot done, certainly in the United States. You know, and it's kind of like LASIK. Was it myopic? That's better. Was it an extreme amount? That's even worse. How many cuts did they have? Did they have bizarre patterns of cuts? Believe it or not, you can also look at the quality of the radiokeratotomy. If you've seen these, you know, in Houston, I can tell you 9 times out of 10 who did the radiokeratotomy, which surgeon, just by looking actually at their pattern and how good the incisions are. Subepithelial fibrosis, little things like that. You think, and that's just under the epithelium actually. You think, well, that's not a big deal. Well, look what the patient actually was able to draw it. So it is a big deal. Things like that need to be taken care of. It's really the history. And then beyond radiokeratotomy, you've got your previous corneal surgeries from myopic keratom lucis, epikeratoplasty, penetrating. This may sound like a history lesson, but you're operating on older people. And these are the surgeries that they have had and will bring to you. So how about lens selection? We use certainly standard IOLs, but we also use extended depth of focus, and we use trifocals, and we use light adjustable lens. We're able to get 87% of these people to where they say they're never or only a little wearing glasses. Now, we used to use primarily extended depth of focus, and we could generate numbers. This is my data, other people's data. We could generate data and patient satisfaction with glare and halos that matched FDA trial results. Why is that? A couple of things likely. First of all, most of these are RK, are myopic LASIK, and those are the people that are most sort of incentivized to do well. They've already proven that they can adapt, they have neural adaptation, that they can do well with these people. And then likely, especially with EDOF lenses, and I've gone through this with optical engineers and partially understood it, but there actually may be points to where the EDOF is especially tolerant to astigmatism in these people. I've seen good results. This is Fisher and Potvin's data with restores So don't necessarily rule out. Now, of course, when you go to a complex lens and a complex cornea, it can be logarithmic in these in your problems. So choose the best patients first. But a myopic LASIK patient, a well-centered hyperopic LASIK patient, I really don't worry. But a real godsend to these is the light adjustable. This is a silicone lens. You think of it as a monofocal. You can put it in the capsule or the sulcus. Very easy to exchange. And that's important in these patients because you will be exchanging more of them than you will standard cataract patients. But oh my gosh, it's so easy. You don't have to do special preoperative measurements. You don't mark the cornea for astigmatism because you're dealing with that afterwards once your spherically induced astigmatism has died down, once the cornea has settled down. And RK corneas fluctuate immediately postoperatively. Standard cataract removal, we do not do intraoperative aberrometry on these patients. If you have to take one of these out, if you haven't yet, this video, there we go. It's going a little slow, but on Zoom, but trust me on this one, they spin out 2 years later easily. So it's a wonderful lens to, be able to exchange. So when you do get a lens in, and just a word about exchanging, run through your options before you exchange them. Is it the capsule? Is it the lens? Is it the cornea? Put on a hard contact lens again. Ask them if they ever saw well. Did they see poorly from the start? Might be the lens. Did it get worse over the time? Might be the capsule. Last lens I'll mention is the trifocal. And we have started using PanOptics, which we really like this lens. I mean, the results are phenomenal, but especially with glasses-free visions. But we've started using these gingerly in post-refractive corneas, and we have surprised ourselves how well they do. So I see us doing more of those in the future. Now, we're not perfect. This is actually a picture of our post-op parking lot for these patients. So, admittedly, it's tougher, and admittedly, your results may not be as good as they are with the perfect non-previously operated cataract patient. But, be careful, studious, cautious, watch your results, and these patients will be your happiest postoperative patients. I can assure you that. Thank you very much.
Thank you, Steve. That was a spectacular talk. Wow, your parking lot it was pretty impressive there. Thanks for sharing the image from your parking lot. So perfect. That was a great talk, and we're actually gonna go do a couple of questions for each of the speakers because we've had so many wonderful questions so far that have been asked. I think we'll just do like 2 questions per speaker if that's okay. So we'll start off with Dr. Alpins. And one of the first questions came out is that with the pandemic and some of the challenges going on, what's the chance that a lens actually won't stay stable and you have to go back and re-rotate? So, obviously you've shared like a very powerful method for calculating the correct axis, but even with the best calculations, lenses may rotate. So are you concerned about using a toric lens in this situation where we are now, or do you feel comfortable that the results are pretty outstanding overall? Dr. Alpins.
Good question, Bill. And the answer is that the need to rotate has gone down in my hands, and it's probably my experience. Maybe the lenses have had some modification, but I mean, we tell all the patients preoperatively, just like you do for a refractive laser patient, there is a small chance you're going to have an adjustment to make it better. So like our laser retreat is probably around is 1%, less than 2%. Torics is probably similar, maybe 3 to 5, but getting less than that. So the answer is it can happen. And certainly if you think you're going to get an improvement like in the example I showed you, it's definitely worth going ahead. And one of the questions was, well, you know, as you said, with the pandemic, is that an extra procedure that is a greater risk? To do a rotation, there isn't really a lot of manipulation going on. You just need to, if you do it around about 3 to 4 weeks after the initial surgery, you just need to elevate the leaf of the anterior capsule on both sides, use a separate incision and come in like from 90 degrees away from each other. So it's astigmatically neutral. And just with the Sinski hook, you can just rotate it as many degrees as you need using, say, a Callisto or other imaging device for your starting point. And you know how many degrees you have to rotate it, like in that case with 18. So you don't really have to know where it is. You just have to know you've got to rotate it 18 degrees. And the imaging device is going to help you with that. So the manipulation is very small. I wouldn't say that the pandemic is an issue. And if it happens on the first eye, and we're going to do the second cataract within 2 to 4 weeks, I'll go and do the manipulation of the first eye on the same day that I actually do the second eye's cataract, because the risk is so low. This is, as you do these days, bilateral cataract surgery, same day cataract surgery. Doing a manipulation for a rotation is not a big increase, is not an increase in risk as I see it.
Perfect. That was a great answer. I'll ask the second question I thought that was really interesting is, so we have so many devices for measuring corneal astigmatism. We have, you know, keratometry, biometry, topography, tomography. First of all, is there one that's the very best for figuring out the right axis and power of astigmatism, or do you need to use multiple devices? And just help us work our way through that whole concept.
Yeah, so great. Another great question, and the answer is do all the measurements. You know, we start off with like 6 measurements, but I also like using core T anterior and core T total. I also use total corneal power off the device, because if you don't use core T total, you can still get total corneal power off the 3 major devices, being Galilei, Cam, and C is so serious. So when I look at all the numbers, I look at the magnitudes, and then I look at the meridia, and I try and see where core T total sits in amongst all those. And usually it's somewhere, it's a tiebreaker. It's usually right there near the center of all of them. So I use core T total, and as I say, you can use total corneal power from the tomography itself, and use that in the calculation for the initial power of the implant. And so that really gives me the greatest accuracy. And I think that also you need to take into account the flattening effect of your own surgical incisions. So you want to know the history of your own incisions, and not just the SIA, because that's kind of like a number that's comprehensive, that kind of encompasses both flattening effect and torque. So you want to leave out the torque and just know the flattening effect of your own flattening effect, which is going to be a little bit different whether you're operating at 90 degrees or you're operating horizontally at 0 or 180. So you want to know the history, a bit of a history of your own incisions, much as I showed in the 2006 paper in the Journal of Refractive Surgery, where you show all the incisions around the eye if you do on-axis incisions. And so that your own history gives you the flattening effect. So you need to take the flattening effect into account. And if it's going to be on incision, like I showed in the example, you're going to reduce the power. I tend now to move to temporal, slightly upper temporal or lower temporal, being a right-handed surgeon, because you just don't want to change anything. And so when you do the incision on the steep meridian, things tend to change a lot. Whereas if you do things on the flat meridian, we showed, it's pretty static, nothing changes much. So in toric implant surgery, you don't want your incision to change anything. So you want to go to your most astigmatically neutral position on the eye, because that's going to give you the most consistency. So in the case I showed, we reduced the power of the implant by half a diopter, But if you've got an astigmatically neutral incision, you know where it is for your own behavior of your own incisions, then you're not going to reduce the power of the total corneal power. You're going to use that exactly for the power of the toricity of the implant.
Perfect. Thank you so much, Noel. Dr. Ashvin?
Dr. Rohit, what in the Indian setting do you do for the machine in terms of which device do you use to measure the corneal astigmatism? One, and anybody else? I think Dr. Jeewan, if you can answer, what's the maximum and minimum amount of corneal astigmatism that you correct with a toric implant?
I think what I am doing now is I'm using the Barrett toric calculator, because this Barrett toric calculator is probably giving an excellent result because it is not data based. It is based on calculations. No doubt it takes into account some bit of database also. So that is the first thing which I'm doing. So the results of this, I'm using the IOL Master 700 for calculating the posterior corneal astigmatism also. But the results with Barrett calculation, Barrett toric calculator is still better than Barrett with TK. So that is what I'm usually taking into consideration. That is the first point. Centroid I'm using for my surgical induced astigmatism as 1.2. I'm using my incision primarily in the temporal incision. So another thing which is there is that toricity ratio is something which I'm asking my lens dealer whether they are calibrating the toricity ratio or not, because at times, you know, they are keeping it at 1.5 in all the IOLs. So, and one more thing, what was the second part of the question, if I'm permitted to ask?
It was towards what's the maximum corneal astigmatism and minimum corneal astigmatism that you take a toric implant for?
Well, if the posterior corneal astigmatism has been taken into account, so, you know, from anything between 0.5 to 0.6, I usually do on axis with opposite clear corneal incision. And those patients who are asking for flax, I'm using the, you know, the femtosecond laser assisted incisional keratectomy in those patients. But above 1 in all cases, whether it is with the rule or against the rule. But if the patient happens to be a young person, with the rule, I undercorrect slightly, and against the rule, I completely correct.
Dr. Jeewan, any comments on this one?
I think Rohit has answered very nicely all the things, but considering the fact nowadays we talk about trifocals and multifocal lenses or extended depth ERB lenses, there I think the amount of astigmatism which we take into consideration would be less than 1 diopter also. But if using a monofocal lenses, yes, I would say 1.25 diopter would be the lower range for most cases. But the standard lenses which are available to us will correct the corneal astigmatism up to 4 diopters. And in the Indian scenario, we have a lot of Indian companies giving us a customized toric lenses which can correct up to very, very high numbers also. So upper limit is, you know, not exactly can be say cut off there, but you can have a customized lenses. But majority of our cases will be, you know, in the range where most lenses are available. But I understand it is the importance would be for a multifocal and trifocal lenses for getting up to less than 1 diopter cylinder also.
If I can make a comment also, I agree that up to about 4 diopters of astigmatism can be corrected with toric. I would like to emphasize that if the patient has any signs of forme fruste or keratoconus and they have higher cylinder than 4, I would urge not to, you know, do any limbal relaxing incisions in addition to the toric, because obviously that would decompensate the cornea.
I can comment on that. I recently had a patient who had post-refractive ectasia, a patient of mine from 20 years ago. I'd been looking after her and did cross-linking and got the cornea stable. She ended up with 6 diopters of astigmatism in one eye and 8 in the other from an eye that was previously close to spherical. So she was post-refractive. She was keratoconic or keratoectasia secondarily. And so I treated her for 8 diopters in one eye and 6 in the other eye. And the results were really, she was very excited being unaided 6 in each eye and hadn't seen that well since she used to wear glasses. So I think you can go higher than 4. You can go, in her case, up to 8 in one eye and 6 in the other.
Perfect. So these are great, great topics. I was going to just jump to the next question, and this was aimed towards Neda, but it's really the same theme. Dr. Shamie, the question is, how do you determine whether whether a patient is a candidate for a toric implant if they have keratoconus? So you see a patient with keratoconus, they have a cataract, but in what situations can you use a toric lens, and when should you avoid a toric lens?
Yeah, I think the history helps a lot. If the patient tells you that glasses or prescription glasses gave them sufficient good vision, or soft contact lenses were tolerated and the vision was good, that tells you that the irregular astigmatism is not a huge component in their visual rehabilitation. They need to understand a toric lens would not be equivalent to an RGP or a scleral lens vision. The other obviously is imaging, and when you do topography or you look at the curvature of the cornea, if the central visual axis, if you really mark the central 3 millimeters and not look outside that area, and if that is bow tie and symmetric, then that tells you that that patient will likely be correctable with the toric lens.
Beautiful.
Dr. Partha, what would you do in these cases, and when do you take up these cases in keratoconus if you find a case for toric lenses?
The keratoconus, it was a very interesting talk that you gave, Neda. And I really liked all the case presentations that you gave, which were very, very important as to understand that when to take up what. So first and foremost in keratoconus, the cataracts appear a little early. But do we jump to a cataract surgery as soon as it appears? So, well, I think the answer is obvious no. So we try and improve the vision as much as possible. And it is only when that both the corneal topographies are showing that there is no progression. And here I'd just like to emphasize one point. During the surgical procedure, not a corneal incision, but a slightly scleral incision is something that I choose for my patients, so as not to induce any amount of astigmatism or not to make it irregular either. And thereby, if it is, as you very, very rightly said, that if it is a symmetric bow tie, these patients do extremely well with toric IOLs. So but of course, if it's a very high diopter, a very high astigmatism, and the possibility of a slight change in the axis can lead to a lot of deficit of the final visual outcome. So it's very important to counsel these patients as well that maybe a rotation or a second surgery might be required at a future time. So these are a few things that I think I just thought I would comment on.
We'll do one question for, yes, Dr. Rohit, and then we'll do one question for Steve, and we'll move on with the program after that.
I think maximum rotation occurs in the first hour after surgery. So that is what is the most critical area, critical time in the whole surgery. For that, we have to be, so there are a few things which have to be borne in mind, that the incisions have to be perfectly sealed for that matter. Because if there is a non-sealed wound by any matter, be it the side port incision, with the efflux of the fluid, there can be some rotation. So sealing of the wound is very important in these cases. In the first hour after surgery, I usually ask the patients not to go in for much of movement. So I ask the patients to remain in a supine position for at least for the first hour itself. So that is what I usually add in my routine of patients.
All right.
People. Thank you. I have a question for Dr. Slade, and then we'll ask the panelists as well. So Dr. Slade, thank you for your fantastic talk on cataract surgery in patients with previous refractive surgery. One of the challenges comes, you have a patient that they've had myopic LASIK, you look at the topography, it's beautiful, and they want reduced need for glasses afterwards. You have a lot of options in your arsenal right now. You have the Symphony lens in the US, we have the trifocal, and you also have the light adjustable lens. I know internationally there may be even other options. What do you do for your patients? Which way do you go if they want to say, Dr. Slade, I really don't want to wear glasses after surgery right now in 2020?
Okay. Well, that patient has unrealistic expectations, Bill. So
Okay.
the first thing I would do would be not go to the operating room. I would go to the examination room where you actually talk to the patient. And, you know, once again, as I said, these patients are tricky. You have made them almost, you know, a 30-year-old -3, you remember those. They're like perfect. So it's not realistic for them to say, gee, I don't want to wear glasses at all. But maybe your question was more along the lines of which gives the best results. And if it's a LASIK -3, they're so close to normal that I will counsel them almost like our non-operated corneas. And I'll, you know, if they're more after perfect distance, they like a little monovision, I'll tend to go to the light adjustable, which is very available in the US. If they want their best chance at not wearing glasses, I'll tend to go to the PanOptix. So they're closer to an FDA trial patient. Last pearl is that RK patients, LASIK patients, all these people will not see as well on day one post-op in general as a virgin cornea. So lower that expectation. You know, don't, you know, when they come in and they go, gee, everybody in the waiting room is seeing perfectly, but me, you know, it's best if they might expect, tell them they're special and that they're going to see better than an astronomer or something, or better than Bill. Anyway.
Thank you.
I just want to make one point here. A patient who have all undergone previous refractive surgery, maybe a radial keratotomy or a LASIK, in these group of patients, I would normally advise we should do a wavefront analysis for these patients. I use eye trace for all cases to see what is actual corneal wavefront for these patients, aberrations. And that will make you know, your decision much simpler. If the cornea is too aberrated, then I think trifocals or multifocals should be avoided in such cases. Maybe you go for a plain spherical lens and try to remodel the cornea or before doing a surgery also. So I think that's an important point people have to take into consideration.
Sure. Beautiful. Thank you so much. Ashvin, should we go into your talk now or do more?
We can move to my talk. I just want to say that Dr. Partha probably has to leave to another webinar. So thank you, Dr. Partha, for being here. It's been a pleasure.
Thank you very much. Thank you. Thank you so much, everyone. Thank you. Thank you so much.
Thank you. So I get the pleasure of introducing Ashvin Agarwal, who, I mean, there's so much to say, and yet, you know, he's also very humble and he probably doesn't want much to say. So I'll just say that I just share experience that if you get a chance to, and Dr. Slade, like you said, actually go visit Ashvin and Amar and Susan Jacob in Chennai and get to watch them in surgery. They're brilliant surgeons and you learn so much by spending time in the operating theater with them. So with that, Ashvin, we're looking forward to learning more pearls about surgery. Thank you.
Perfect. So my talk today is on, sorry, I just shut my own screen. Yeah, okay. My talk today is, can you guys see my screen?
Yeah, it's there, yes.
Perfect. It's on managing subluxated cases. And in order to manage these subluxated cases, I think we have to first understand how do I look at subluxation. I look at subluxation in two forms. One is the severity and the second is the pathology. If the pathology, and I'm talking about pathology first, is if it's a congenital disease or it's a progressive one or a traumatic one. Any of the first two, I would straight think of probably not having the bag for a long period of time. This bag is diseased and is not going to stay for a long period of time. And you want to not deal with bag issues after placing an endocapsular ring and an IOL and so on and so forth, which we would find, and we've found many of these cases having the bag IOL ring complex on the retina. The second being said is the traumatic and iatrogenic ones, which I deal with when it comes to severity. And I know there are many options out there, but this is something that I do on a personal basis. So let me just explain what I do. One is the capsule tension ring, which is if it's less than 3 clock hours, I just place a capsule tension ring and that's about it. If there is 4 to 7 clock hours, I probably put a suture segments. And nowadays I put a paperclip hook, which is what I will be showing today. And the third one is if in case it does happen, there's a intrascleral haptic fixation with no sutures. I personally don't like sutures too much because they have their own issues to deal with. Talking about the paperclip capsule stabilizer, I think it's a uniplanar device, and I think it's made out of PMMA by Mocha. I have no personal financial interest in this, but what basically the paperclip hook does is it goes under the anterior capsular rim in a 2-point contact with the capsule edge, the anterior capsule edge. It does not take care of the equator, so you really need to put an endocapsular ring as well to actually stabilize this. What is the advantage? We'll come to that as soon as I finish the video presentation of the paperclip hook. So basically, here's a big subluxation. I'm basically making a scleral flap at that site. After doing my capsulorhexis in these cases, you can see very few zonules out there, which are just holding that bag in place. I'm making a 23 gauge needle entry in the sulcus space behind the flap. Hold that with a gluteal forceps, pull that distal end out. Now I'm making my capsular hooks to hold the bag in place intraoperatively. This is just to be intraoperative. Now I place a Gabor-Chariot's tunnel, cut off the excess of this stabilizer and place it into the tunnel. Once this is done, and once the nucleus kind of comes out easily, but what happens is the bag kind of crumples on itself, and that's something that you want to avoid. So you place a capsule tension ring. I like to drop the capsule tension ring rather than dial it in place because that really doesn't help me. After doing that, I perform a complete irrigation aspiration. Once my irrigation aspiration is out, I remove the capsular hooks. I leave the paperclip stabilizer here, and I place my intraocular lens in place. This is how it looks immediate post-operatively on table. I put some glue to kind of close the flap because I really need sutures as it's up to the eye itself. And I just glue the conjunctiva as well. So this is the first day post-operative of the pictures of the patient. And this is how it looks on table, on the slit lamp post-operatively. Here you see the haptic inside the sclera. Using a UBM, you can actually do this. Having said that, you can place two. I've not done it yet, but yes, I've seen cases where Susan has done this. This was devised by Dr. Susan Jacob. Yes, these are the advantages. This is just for the audience. If they want to take a snapshot of that, that's perfectly fine. But major advantage, which I would say, is that you don't need to use sutures, and all the suture-related degradation and issues that come with erosion are not there anymore. You won't find any more dangling bags. But sometimes things are not so clear, and you would find this on table many times where you see that you've shaken the eye, everything looks good. And once you go inside, I always make this Wong incision in my cases, especially in the routine cataract surgeries. But once I go in, I start seeing that this bag is not so steady on one particular side. And on that particular side, I start to place a capsular hook in place. Once I've placed my capsular hook in place here, I kind of do my hydrodissection just to hold on, just make sure that that bag does not dislocate or does not move around too much while I'm doing my phaco emulsification. Once I've done my phaco emulsification with the probe, and now make sure that, ideally don't try to do that, but irrigation aspiration is pretty clear if you keep the capsular hook in place. If you remove that capsular hook, it gives a chance for the vitreous to kind of come forward, and you might have some vitreous disturbance. And always take that last piece out at the end. And there you saw that. You saw the bag was a little, zonal dehiscence was definitely there. And in these cases, I don't actually intend to do, because this was a pseudo exfoliation and so on and so forth, I don't intend to retain the bag in these cases for a long period. I've not done any vitrectomy, I've not done any infusion. Keeping the capsular hook, which is keeping my vitreous at bay, I'm now passing 22 gauge needles and doing my intrascleral haptic fixation using a Yamane hybrid technique over here, but it's basically to externalize the haptics. Once my first haptic is out, I'm now holding on to that while inserting the trailing haptic inside. Now placing my, through the sulcus space, I place a gluteal forceps to grab the tip of that haptic and bring it out. Again, I have not vitrectomized this eye. There's no infusion, which doesn't need to be. Now I remove my capsular hook because now I know that there is no disturbance of vitreous that has happened up until now. What this does is basically avoids any vitreous disturbance. I don't need to be, as an anterior segment surgeon, I can perform this. So I've basically placed this lens in the sulcal space without any use of disturbing any vitreous or anything of that sort. And here is my glue, which I'm using to close the flaps. And this is a 3-week post-op 6/6 patient, is brilliant, very, very happy in these cases. But things can become even worse. So once the subluxation ends up to be like this, you really want to know what to do. If it's a soft cataract, again I repeat, if it's a soft cataract, only then perform a glued IOL scaffold. A scaffold technique is basically what I'm trying to do here is make my intrascleral haptic flaps. Once I've made my flaps, I push using a modified power technique. I push this complete bag complex up, use some pilocarpine to reduce the size of the pupil. Anterior vitrectomy is now done. After performing the anterior vitrectomy through the ports, I'm placing my intraocular lens under the nucleus, under the whole bag. And since it's soft and it's transparent, I can actually visualize every bit of it and visualize the haptic tip and externalize them. I only need 2 millimeters of the central pupil. Once this is done, because it's soft, again, this is why this has to be a soft nucleus for me to do this. I can just emulsify it without even using any phacoemulsification power. So that was done on pure just irrigation aspiration mode. And once this is complete, I close the flaps, close the conjunctiva, and that's the end of the case. That was day 1 post-op. If you have a hard nucleus, what do you do if you have a hard nucleus? Same case, almost same case. If you have a hard nucleus, the best approach that I have seen till date is using a scleral tunnel. So make my flaps using a crescent blade. Once I've made my flaps, I also make a scleral tunnel here. This is my scleral tunnel to ensure that the nucleus can, or the bag complex, whichever it is, can come out without any force and without any traction or least amount of traction possible. What I'm doing here is again a modified PAL technique to bring it up into the anterior chamber. Once it's up in the anterior chamber, I now open up that wound, make sure that this whole bag complex just comes out, suture up, and now do my anterior vitrectomy, perform my anterior vitrectomy to ensure that the whole, as you're seeing here, all the vitreous is still present. Once it's not present, you'll see that the pupil kind of shuts down. Now I can perform my glued intraocular lens. If you're doing a Yamane, do a Yamane, whichever lens. You can use the Alcon lenses as well. Absolutely no problems. And here you are performing the glued IOL technique. And once that's done, the Gebel-Chariot's tunnel is made and the haptics are tucked into the Gebel-Chariot's tunnel. And here we are with closing up this case. This is pretty much the end of the case where I close the flaps and the conjunctiva with glue, and you have a taut eyeball. That's pretty much how I deal with. These are some of the reasons why I don't use sutures in most of the cases. And I've pretty much done away with sutures from all else. Thank you very much.
Ashvin, that is always amazing. I know that I watch your videos and go, wow, if I could only do all those procedures, I definitely need to keep learning and becoming, learning all those technologies and techniques. Thank you for sharing so much. I know we're going to do questions and answers after the next couple of talks. So we're going to just move right into our next speaker, Dr. Sumitra Khandelwal. And Dr. Khandelwal, as everyone knows, is just a wonderful surgeon. She does cataract, refractive, and corneal surgery. She's a professor, associate professor at Baylor College of Medicine, and she teaches residents and fellows. She speaks at meetings both in the U.S. and internationally, and we're super excited for you to share one of my favorite topics, since I am currently wearing some glasses right now, temporarily, hopefully, is presbyopia solutions that work. Thank you, Sumitra.
Well, thanks everybody for having me. It's always fun to follow one of Ashwin's talks with all of his cataract gymnastics. So we're going to kind of change back a little bit to, presbyopia solutions. And as Bill mentioned, I teach residents and fellows, and a lot of times they're just like, how do I get started with presbyopia correcting lenses? It's very overwhelming. So hopefully this talk can engage those who are maybe just starting out, are interested in presbyopia correcting options, and even those who are already doing it but just want to have a different perspective. And so I think the key steps to success are to understand the patient's goals, do a great preoperative exam, that's even for all cataract surgery, not just presbyopia correcting lenses. Be familiar with the options, and there are a lot of options now compared to 5-10 years ago, and know how to troubleshoot. And so how do you understand the patient's goals? Well, I think surveys are a great way to not only have something written where you can read a little bit about the patient before you walk in the room, but also it makes the patient think a little bit. So thank you to Steve Dell as well as Elizabeth Yu for providing some of these different variations for lifestyle goals. This is one survey, for example. I like this one because it makes the patient think about what it is that they really enjoy doing and what it is that their goals are for cataract surgery. It also has the bottom that says, place an X on the scale that describes your personality the best, goes from easygoing to perfectionist. I think that's really helpful for us as surgeons before we walk into the room, understanding where we're going to be as far as the counseling and discussion goes. This is a different survey that I've kind of moved towards a little bit more, especially with the introduction in the US of PanOptics, because now we have less of a discussion of distance, intermediate, and near, and more of a discussion of what the goals are for the patient. Really, the key for this very simple questionnaire is number 4, which is, if you needed to pay for it, would you be willing to for, some sort of spectacle independence option? And are you okay with some photopic issues like halos, rings, or starbursts? And so different ways for you to approach these patients based on your practice. I think a proper pre-op exam is important regardless of if it's presbyopia correcting options or not. Topography, retinal OCT, an excellent ocular surface exam. Here are some examples. I love Placido imaging because it really trains my staff to stop the cataract evaluation early on if they say any irregularities to the Myers. The retinal OCT is a great stopping point. I definitely can admit that my retinal exam is not what it used to be when I was a resident. And so missing small little macular pathologies can really, really affect things. And I think having that information before you even start to discuss options with the patient is very helpful. And then of course, ocular surface, not just frank staining, but things like lid margin disease, tear breakup time, and optimizing that. And then the real crux is, how do you familiarize yourself with the options? It used to be simple. You had monofocals, and then you had multifocals, and maybe accommodative. And it's just gotten more and more options, the EDOFs, the LOADs, the trifocals, the quadrifocals, toric options for some, but not for all. And I think it just really gets confusing. There's too many options, certainly for the patient, but we as surgeons need to guide them into, what the best lens is for them. And so I'm going to try to break it down in the next few minutes. We'll start with monovision. Monovision is something that is exceedingly popular, especially for those in their 40s and 50s who are entering the realm of presbyopia and want some option to be spectacle independent. It's a great option. And we have many referring optometrists that start these patients out in monovision contact lenses. The key with it, though, is that a 45-year-old or a 50-year-old who's doing monovision with their contact lenses is very different than a pseudophakic patient who's doing monovision. The good is there's optimal visual quality, a high rate of satisfaction, and it's often testable with a contact lens before. The downsides is that you do lose some of the, stereo acuity, and that can definitely be a situation above 1.5, and some of these patients are a little bit older and may need some of their depth perception. And then there are issues with true spectacle dependence. I think many of these patients will wear balance glasses, maybe nighttime driving glasses, so you want to counsel them accordingly. And I really want, when you see a patient who's done monovision, it's very easy to say, hey, that's great. They did it in the past. I'm going to do it now. My conversation's done. But I like to delve into a little bit more. How long ago was the monovision? Why did they stop wearing contact lenses for monovision? And how accepting are they for spectacle dependence for certain activities? Because if the answer was, look, I just stopped wearing my contacts, I got tired of them, it was up to last year, and I have no issues with balanced glasses, I think these patients do very, very well. And you can go with, sort of a mini monovision for them, intermediate, and the non-dominant eye. But if they said that they did monovision many years ago, and they couldn't remember why they stopped wearing it, but maybe the vision wasn't as good, that patient may not be tolerant of monovision now that they're in their 60s and they truly have no accommodation. And you really want to delve into, maybe this is an option where a multifocal lens, a LOAD with maybe a mix and match, or maybe a trifocal can really be a great option for these patients. And so I think it's important that just because they did monovision 10 years ago, are they truly a monovision candidate now? And I think the keys to success are a history of successful monovision, doing the near eye first, so you can really nail that emmetropia. I especially like that in patients who are lower myopes or myopes in general, because you give them that minus 1.5 to a minus 2 in their near eye. And some of them are like, this is great, just match me up. And some say, no, I want more distance in that dominant eye. And then the counsel for need for glasses. They're higher ad multifocals in general, because you lose that intermediate vision in our new world with phones and tablets, and webinars like this is very much intermediate based. I think especially that, plus the introduction of quadrifocal, trifocal options, has really been something that I haven't used anymore. And so I think that's one that if it's too confusing to have these options, that's one you could probably drop from your arsenal, because there are better options now with the quadrifocal and with lower ad multifocals. With the lower ad multifocals and the EDOF, the nice thing is that you have this less diffractive ring, so less photopsia, and there are torics available, and it provides that intermediate target for these patients. 18 inches or 45 centimeters more or less for the 3.0, for example, on the Restore platform. 2.5 can give you a little bit more intermediate, a little bit less near, and you can do some mixing and matches. There's lack of repeatability of the near, so that is definitely a concern for some of these lower ad multifocals, and you still could get some glare and halo, but I think everyone can agree that it's much less than some of the traditional multifocals. I personally like the Restore because of that central clear zone. I find their distance vision is very good, but also I like to mix and match a little bit. So my approach for these patients is to start with the dominant eye. So that's different than the monovision patient. Do the Restore 2.5. If they're happy with the range of vision, just match it up, keep it simple. But if they want a little more near vision, then they can do the Restore 3.0 in the other eye. And the Symphony, which is available in the US as well, has also provided a really great option and an alternate to lower ad multifocals, plus a toric platform as well. And this can give you more of this true extended depth of focus that gives you the distance, the intermediate. And for some patients, their near can actually be quite good. For these, once again, the dominant eye is preferred to do first with the Symphony. And if they're happy with it, you can do the Symphony in the other eye. You wouldn't want to necessarily go for anything other than emmetropia in these Symphonies, because they can get some visual phenomenon. If they want more near vision in the other eye, then many of my colleagues actually do a ZL Boo in the other eye, and then they get kind of that blended vision between the two. But you do have to be a little careful with the EDOF lenses, because some of them can get the spiderweb phenomenon, and some of them have required IOL exchanges. It just depends on what type of counseling you'd want to have with your patients. I prefer to have a little less near vision and go with the other platform, but I think patients can be very happy with this platform as well. And then really the game changer for us in the US has been the introduction of the quadrifocal lens, because unlike the other platforms, you get that intermediate, that near, and their distance. And for us, that's the PanOptics in the US. It allows you to have much easier conversations when you have a patient that has a characteristics in the pre-op exam that make them great candidates for a multifocal, because you no longer have to decide between intermediate and near, and what is their intermediate and what is their near. You really can provide a lens that provides all three focal points, and it's a low dependence on the pupil size, but you still are going to have a little bit of concern with glare, halos, and contrast sensitivity. There's still a lot of choices. So I think the way that I break it down as far as how you should think as a surgeon, especially if you're starting out, is, does the patient desire spectacle independence? And if they do not, and they don't really want to discuss anything that's out of pocket, then a monofocal is an excellent option. And if they want to look at options that, you know, like a toric or perhaps monovision, you could definitely discuss that with them. But, you know, don't ever assume that somebody's not interested in spectacle independence. Many patients are. So I always have the conversation that there are different lens options available. If they want spectacle independence, I think, be honest, is this eye truly a candidate for anything other than a monofocal or a toric monofocal? If they have macular pathology that is moderate to severe, if they've got moderate to severe glaucoma, if they have a cornea that's extremely irregular, the discussion tends to go towards a monofocal regardless. But not all abnormal is truly a contraindication. If they have issues where you have a little bit of concern for contrast sensitivity, maybe milder macular pathology, maybe milder glaucoma, perhaps they have had refractive surgery or RK in the past, you can keep it simple and go for the monofocal. You can look at these low AD or extended depth of focal options, and definitely counseling these patients that their eye is not a completely pristine normal eye, but if they're very motivated for spectacle independence, there are these options. Perhaps do that dominant eye first, and if they're happy, you can just, you know, match it up with the other eye. If they want a little bit more near, but they're happy with the distance, go for a mix and match option. Or if they're not that happy with the first eye and they felt, you know, man, my distance vision, my contrast is not that good, it's not always impossible to do a monofocal in that second eye or give them a little bit of time. That's a whole other discussion about troubleshooting, you know, patients who maybe aren't as happy with these different presbyopia correcting lenses. And then, you know, if their eyes is something that you're not as concerned about halo or contrast, perhaps it is that mild myope who's had refractive surgery, or one who's had no refractive surgery, their cornea is pristine, their macula is pristine. It's great to offer this quadrifocal or trifocal options, because I think that really reduces the discussion of different focal points, and it really comes down to, are they okay with some halo, some contrast? And a lot of patients are, and these patients are extremely happy that I've placed the PanOptics in, because they feel like for the first time in a long time, they've got 3 different focal points. And so really, I mean, the key is, you also want to know how to troubleshoot, and you could spend a whole 30 minutes on different ways. But one of the interesting things is when you look at the reasons why patients are not quite happy, it really comes down to, you know, residual refractive error and some ocular surface issues. That's kind of the 2 main reasons for that. So I think if you can address the ocular surface issues and any concurrent issues prior to surgery, and if you can really work on nailing that target, especially in the dominant eye for distance, and using a lens that has great distance quality of vision, such as you know, the low ads or the you know, quadrifocal lens, I think you can really solve some of these issues that we've had. And that's what's given presbyopia correcting lenses kind of a bad rep in the past, but the reality is these patients can be very happy if you do the work on the front end. And so, you know, it's not which lens is best, it's what's best for the patient, and you have to determine how this fits into your practice, and definitely read up on different ways to, you know, troubleshoot any patients that come in happy. But I think if you follow some of these, that number will be very, very low. Thank you.
Thank you, Sumitra. That was amazing. It was fantastically put together and really, really well done. Bill, all yours.
Absolutely. Yeah, again, Sumitra, great talk as always. And now we get to get our final speaker, who's just an amazing speaker. I've had a chance to be on virtual programs with Namrata Sharma previously. And Ashvin shared with me, Namrata, that you actually have been part of over 100 virtual presentations in the last couple of months. Is that about right?
Yeah, that's right.
Oh my gosh, wow. Namrata, you know, when I got a chance to listen to you, you're a fantastic speaker, obviously a fantastic surgeon in cataract surgery, refractive surgery, and we're super excited to hear your talk today. Thank you for being with us.
Thank you so much, Bill, and thank you everybody for inviting me to this webinar, which is having great presentations. And I'm going to be talking to you about the guidelines which are there for cataract surgery in the COVID era. And this is pretty much the work of the entire All India Ophthalmological Society Governing Council. Ophthalmic practice guidelines in the current context of the COVID-19. And this is the document that we prepared. Actually, it is a 104-page document which gives you insight into what you should do in the COVID era, not only for cataract surgeries, but for each of the subspecialties. And these guidelines are of course, as per the Indian standards, the advisory and the regulatories which were given by the government of India. And of course, we've left it to the clinical judgment or the decision of the physician whenever there is any conflict. So this was a result of teamwork of 225 plus experts with 13 subspecialty societies who got together with 20 plus Zoomers. And these are just the pictures to show the same. And these are all subspecialty societies in our country. The IRSI leading at the top, Eye Bank Association of India, Cornea Society, Uveitis, Vitro-Retina, Oculoplastics, Glaucoma, Strabismus, Neuro-Ophthalmology, Trauma Society, and even our Ministry of Health and Family Welfare representatives, because we wanted to get all of them on the same page, and we wanted to come out with the comprehensive guidelines as to how to advise our ophthalmologists in our country, because ophthalmology is going to remain the same, but the way we do the ophthalmic practice now is going to be a little different. So we are advising a declaration or screening form for the COVID-19 patients in which they have to declare that they do not have the symptoms. Body temperature would be recorded and triaging would be done. And also they would have to declare that in case they go home and they do get fever, or one of their attendants or relatives gets fever who has accompanied to the clinic, they should immediately report to the clinic so that the appropriate action can be done. So these guidelines are dynamic, which would keep evolving and changing as the situation changes. So planning the functioning of the ophthalmic setup is these are the key points: to minimize the amount of the time patient spends in the clinic, decrease the number of the visits as far as possible, and minimum staff needed to function and delineate the areas based on the flow of the patients. Physical distancing, which has been emphasized on, to fix prior appointments, function with a fixed number of patients per hour, only one attendant per patient. Possibly the patient can wait outside in his own vehicle, and then patients can be called into the clinic, especially when they're being dealt by the solo practitioners. Then history of travel, fever, cough, difficulty in breathing, loss of taste, loss of smell, etc. To be seen, to mandate and download. This is our own app from the Government of India, which tracks whether the patient is coming from a red zone or not, or a containment zone or not. And then every patient and attendant has to pass through the triage area with norms of physical distancing and appropriate partition. In the elevators, there should be demarcation lines to ensure that patients are standing facing the walls, and temperature to be taken by non-contact method. Need for multiple stations based on the number of patients seen. Online payment methods to be encouraged as opposed to the currency, and all staff members to be masked. Reduce the workforce patient contact time, keep the doors open to allow free flow of air, and minimize the contact with the doorknobs with adequate distancing. Avoid or minimal talking at the slit lamp. Avoid re-examination of the patients who've already been assessed by some other staff. Clean all surfaces with appropriate cleaning solutions and protocol, and hand sanitization frequently. Of course, beforehand only you have to tell the patient to get minimum baggage or minimum things to the clinic. At the entry itself, sanitization should be there, and they should be seated in designated seats only, and they should avoid talking to other patients and attendants. Important thing is that when you're doing a visual acuity examination, one may start from the lowest achievable line to speed up the things, and avoid the use of the occluder, and request the patients to close the non-testing eye with their own palm. And when you're doing a near visual acuity testing, hold the near vision chart with the gloved hands at appropriate distance yourself rather than the patient holding it. And at all points in time, more than 2 meters distance has to be maintained. Then refraction has to be avoided as far as possible, and trial frame, pinhole occluder, lenses, etc. need to be cleaned with the alcohol swab or appropriately sanitized, and provide sufficient time to make the surface of these instruments dry. Then NCT is not preferred because that will generate aerosol. We prefer to use a Goldman applanation tonometer. Again, this has to be, the prism of this has to be wiped with 1:10 sodium hypochlorite at the beginning and end of the day. Then breath shields for slit lamp examination. And in suspicious cases of chronic NLD obstruction or chronic dacryocystitis, one can postpone the cataract surgery and take universal precautions for lacrimal sac evaluation. For fundus evaluation, indirect ophthalmoscopy may be done and avoid indentation, and neodymium yak capsulotomy may be considered again with the breath shield. Then you can instruct the patient to pull the lower eyelid by themselves and put a drop for dilatation. Alternatively, use a bud to pull down the lower lid or use disposable gloves. And in general, all the instruments with the headrest should be attached with the breath shield. Then one has to do investigations for cataract surgery. So for ultrasonic biometry, tip of the probe may be cleaned with the alcohol swab. Sufficient time to dry should be given, and in case of immersion scan, even the Prager shell can be cleaned with the probe, with the alcohol. And then these are the breath shields for keratometer. Preferably optical biometry should be done, again with the breath shields. Counseling is important, and patient mingling should be avoided even in this area where there is investigation. We are, some of the centers are doing COVID-19 tests pre-operatively and some of them are not doing. And again, this is at the discretion of the operating surgeon. And these are the 4 things which are required for preparedness for opening the operation theater. That is ACAL, assurance, assure the patients that everything is safe. See that all your clinical requirements are met with, including the PPE. Administrative things have to be looked at to see that the OT schedules are scattered. The utilization of the OR in terms of efficiency of the staff to be monitored, and improve the efficiency by opening up to extended hours and maybe even weekend working schedules if required. Then logistics have to be looked at in the form of teleconsultation, and one has to look at the current inventory to assess the availability of the necessary consumables as well as ensure the constant supply. Recommissioning of the operation theater has to be done depending on the protocol which the institution has been following earlier. And the staff also needs to be screened with the talk history, thermal scanning, as well as the consent of the staff also has to be taken, because the staff should not be blaming you later on, of getting COVID. Then this is the dress for the staff in the recovery room, in the pre-anesthetic room, and for the housekeeping staff. And this is in the CSSD area, and this is for the OT staff and the surgeon attire with N95 masks, sterile gloves, protective goggles, normal OT footwear, and a surgical gown which is preferably disposable. And all these precautions which are there in the OPD have to be followed in the operation theater as well. Air conditioning may require to be changed a little bit, especially when you have a HVAC system where the fresh air passages have to increase, and air changes which are needed are 20 per hour. Those for split air conditioners again would need more ventilation and more air changes. And if you're doing a surgery under general anesthesia, then 20 minutes before 20 minutes later, after the anesthetist has intubated, the surgical team would walk in, and after the surgery is over, again a 20 minutes gap has to be given. The biomedical waste disposal should be done as per the guidelines by the regulatory body, or by the government of India, or by the government of that particular country. And of course, instrument cleaning has to be done even after wearing the PPE. Now, patient draping is most important. The drape has to be firmly stuck around the patient's eye, which should extend all around, and safe distancing has to be ensured. This is the dress which should be worn in the operating room, which has been described before. And one should do the surgery. It should be done preferably by experienced people. It should be done very fast. When you're giving a retrobulbar, peribulbar anesthesia, again, you need to dress appropriately, wearing appropriate PPE. And one has to instill povidone iodine 5% in the operating eye 2 minutes is the contact time. Avoid spillage of the fluids on the gown. And when you're doing a phacoemulsification surgery, sterilized phaco tip and sleeve should be used for each case. The incision size should be 2.2 millimeters in phaco, and apply HPMC on the cornea frequently. And irrigation aspiration has to be done 6 months before the phaco procedure. Now, these are this has come in a video courtesy of Bristol Eye Hospital. All these 4 caveats which need to be followed during phacoemulsification surgery. Post-op care, of course, the patient has to be looked at, but encourage teleconsultation after the first visit. And if there is a problem, only then call the patient. And these are all the references that have been quoted for the same. And these are the people who actually contributed in the various expert groups. And there are a lot of representation from the subspecialty society, from solo practitioners, group practice, corporate sectors, in all the subspecialties. And I've only talked about the cataract guidelines, but these guidelines are there, from each subspecialty. So if you want to look at the document, it is very much there. And I would like to thank the entire governing council for All India Ophthalmological Society for helping to put this, and the back office team who helped to materialize this in a record period of 20 days. So thank you very much for your kind attention. And if there are any questions, I would be happy to take them.
Well, that is lovely, Namrata. I think that's given such a holistic picture to this whole COVID era. And we are all calling it the COVID era. Honestly, everything has changed. I mean, if it's like a 4-volume book almost now. So I think that's phenomenal, the way that you've concised the whole thing in one presentation. So thank you for that, Dr. Namrata. Having said that, let's move on to the questions now. And I think we'll start with Sumitra. Sumitra, there's a question for you that's come up, and I think it's an interesting one. In these presbyopic patients, they all expect much more from their vision correction post-operatively. It's basically doing refractive surgery with cataract. And how many times do you get refractive surprises in these, and what do you do to correct them, and what channel do you use, more of a lens-based or a corneal-based? How do you take care of that?
Well, I think the first step is to set very realistic expectations. My spiel, I guess, that I tell patients is, we've got an opportunity here to allow you to have, distance vision as well as some near vision, but there's no lens out there and no surgery that can make you 30 years old again. And I think you have to really set that expectation early on. They always laugh a little bit, but that's the reality, is that they all want to have that amazing ability to see multiple focal points the way they did when they were younger. So I think you start that out from the very beginning. I think you also make sure that if it's an eye that you think is going to be an outlier from typical IOL calculations, that you don't forget to address that with the patient eye. Who are those patients? Patients who have shorter axial lengths that oftentimes can end up myopic, or actually very strange outcomes sometimes with those patients. Patients who have narrower anterior chambers, once again, there is that risk they'll end up more myopic or even more hyperopic than planned. Longer axial lengths, I think we have a lot of options, a lot of formulas that can really help us with that. And then don't ever forget abnormal corneas, not just keratoconus, but eyes that perhaps had high myopic ablations. They're very flat. And so those corneas too can give you some strange surprises. So in all patients, I remind them if they have any abnormalities that is a concern for them. I think for outside of those, we tend to end up pretty well on target though for emmetropia for other patients. So I think that's the good of it. I tend to go towards some sort of corneal ablative procedure afterwards if they do have a residual refractive error. To be honest, I've had a couple of monovision patients where monovision didn't work out like they thought. That's why I'm very careful with those patients. And the nice thing with those patients is it's not too difficult to put a contact lens, show them what happens if they lose all the near in their non-dominant eye, and let them make the decision if they want to have a true, ablation. And myopic ablation is pretty easy in those patients, but you'd be amazed how many of them you take away that near eye, and then they're like, wait, I don't want this either. You put it on them afterwards. I think a contact lens trial is imperative in the post-op period. I think you give some time to let them adapt. And I think everybody who puts in any lens. It doesn't have to be a presbyopic correcting lens. It can be a toric. It really needs to have the basic ways on how to exchange an IOL that's in the bag for a different IOL more than a month out. I think that if you are somebody who is not familiar with that, that's one of the first things you want to do is learn how to, take a lens that's in the bag 3 months out and exchange it. Otherwise, if you don't feel comfortable with that, have a really great referring doctor who can help you out with that. Because it's tough. It's tough to know if they've truly neuroadapted in 1 month. But we all know that it's tougher to exchange a lens at 3 months.
That's really helpful.
Yeah.
Can I make a follow-up comment about that, Sumitra? That was a fantastic talk and really kind of consolidated all the decision-making that happens when that patient is sitting in front of you. What I can comment on is that the light adjustable lens has added a layer that has simplified much of that discussion. And especially those patients where, you're not sure about monovision, did they like it, did they not, at what point can you get it? Or a patient that you anticipate that they'll probably be fine. I've had a number of patients recently who developed monovision as a result of asymmetric cataract. They weren't even aware of it. And when I brought up monovision, oh no, that's going to be terrible for me. But sir, you already have it and you've enjoyed it. You were wearing reading glasses, and to be able to say to them, well, I can implant this special lens that you can test it out. And if you don't like it, we'll just light adjust it non-invasively. It's been wonderful, and especially for those patients who are hesitant about halos and glare, but they still want to have a possibility of being able to see up close, but they never tried monovision. The light adjustable lens has been amazing for those patients.
Dr. Rohit, do you do anything different in these high expectation patients? And I asked that from a presbyopic standpoint.
I think Dr. Sumitra has been spot on. You under promise and over deliver. Well, that has to be the basic concept of it. And your case selection is also very important in these patients. As Dr. Titiyal put forth, you have to be more aggressive in these when you're putting these multifocal or these trifocal IOLs, in using the toric ones also, because at times, these patients are not satisfied and you don't have the expected results because you're not adding the toric component to it.
Perfect. Thank you.
I've tended to move away from monofocality because the moving early on to the extended depth of focus lenses, it was so wonderful to have that two levels of vision, even though sometimes for near you need something extra. But now with the trifocal and using the Physio IO, it's such an excellent lens. Initially I was concerned and led to believe that the halos and glare are going to be worse than the EDOF lenses, but in fact, in my experience, that hasn't been the case. And so I've been pretty much moved to the trifocals. And so when you have such excellent vision with a trifocal or a quadrifocal, as said, why would you want to leave someone myopic in one eye when you can have good vision for distance for both? Certainly, there is that risk of not hitting emmetropia exactly, but then it's so nice to be able to fine-tune it with laser if your calculations are just a little bit off, and you can fine-tune it so you get that patient satisfaction altogether. So the trifocals, quadrifocal lenses, I use the trifocal lens, has made a huge difference without any negative effect on glare and halos compared to the EDOFs.
Thank you, Dr. Alpins. We're going to jump to ask a question for for Ashvin. Ashvin, you got a number of questions on the Q&A session asking about your paperclip technique. One is the paperclip actually in the bag? How do you decide whether you use one or two in a case? And are these expensive, or how do you get them?
I get them through Susan, number one. For me, it's a little easier, but yeah, right now it's on sale with Morture. I have no financial interest in that, but yeah, Morture does that. But yeah, it goes into the bag, but just only the hook part. Everything else stays above the bag. It's just the hook that goes inside the bag or the anterior capsular rim, and that's about it. And that's why it's called a paperclip hook, because it goes in exactly like a paperclip, the one that goes, and that's pretty much how it goes. The advantage of that is basically it's a 2-point fixation, and so it doesn't tear the capsular bag at any point, number one. And the second is the distal end, which is curved, actually goes into a Gabor-Shariat's tunnel, and you really don't have to do any suturing or fixing with Gore-Tex or any of that. That's one. The other point, what was the second question, Bill?
It was just tips on, on the paperclip, what more.
Yeah, thanks, Bill. I think the only point I would say is please add a capsule tension ring, because once the nucleus comes out of the bag, that bag starts to crumple on itself. And that can only be prevented by placing a capsule tension ring inside at the equator level. So that's my only tip for this.
Beautiful. Any of the panelists want to comment? Anyone else using the paperclip of the panelists, or?
No,
Maybe not paperclip, but if somebody wants to comment on a suture or something else, or we can move on to the next question, which is also very interesting towards Neda. Yeah, Neda, you want to say something?
I wanted to ask you a question. What do you do in a case where there's one piece with a CTR in the capsule has fibrosis and is significantly dislocated? Now with the Yamani technique, would you still lasso that complex, the lens capsule CTR complex, or would you do an exchange and just put a Yamani in and keep it clean?
I always, in those cases, I prefer to do if that single piece is a single piece lens, if it's rigid lens, then I would use the same lens and glue it in. But if it's not, then I would exchange it. But I know, and I would only do that because I don't know the other technique of lasso, one. Second is, I think if people know the technique of lasso, please go ahead and lasso the lens. Retaining the bag, retaining the lens has its own advantages, number one. Second is, you really don't need to make so many incisions then. You really just need those 2 paracentesis incisions and you're able to lasso most of these. And that's why in a single piece PMMA lens, I would just never explant it if it's fully intact. If the lens is fully intact, the IOL is fully intact, even if I have to remove the endocapsular ring, even if I have to remove the bag, I would do all of that through a small incision using a vitrectomy cutter and just glue that lens in place. I have done at least 5 to 10 of these cases and they come out exceptionally well. In fact, they have a bulbous end at the tips of the haptics, which really goes snug fit into the tunnel. And it's very forgiving in its own way because the centration really, you can get the centration, you can get the tilt, everything is just monitored and very forgiving, much more forgiving than the Yamane, in fact.
Yeah. What about the breakage of the haptics of a single piece vis-a-vis 3-piece?
That's very interesting. Actually, it can break. There is no doubt it can break. But I've done, so it's again about tissue handling. I would definitely add a word called tissue handling. If you are good at tissue handling at that point, definitely go ahead and do this. If you're probably misjudging or not getting it right in the previous instance, don't try it, explant that lens and exchange it out. It's much easier that way. Even in lasso, you really need tissue handling is what I understand.
Beautiful.
Yeah.
There's a question for Dr. Sharma. We'll just jump to her, which is asked, which is, okay, if you don't have HVAC, what do you recommend for air exchange in the operating room? Like, what's your best next choice?
So I did put in HVAC and then I put in split air conditioners because I know some of the clinics would not be having HVAC and would be on split air conditioners. So if it's a split air conditioner, then what you need to do is that the ventilation has to increase and the exchanges per hour has to increase. People have even recommended that after putting the air conditioners on, you can actually for an hour or so even open the doors so that the ventilation is there, and then you can work. Of course, it takes a toll on the compressor of the air conditioner, but that's what is recommended.
Thank you so much.
Steve, there's a very interesting question, and I think Dr. Rohit, if you can also answer this after Steve takes this up. Multifocal lenses post refractive surgery, how would you do it? Why would you do it? If so, you can take multifocal or trifocal, whichever goes, but.
Sure. We have done that, and they are trickier. On the other hand, that's your best chance to meet their expectations, right? And for these people, again, the 30-year-old -3, you'll never get a result like that. and they're always wanting that. And so you just don't want to disappoint them. Monofocals are best, EDOFs after that, second best. The Panoptics we are impressed with, but it is all about patient selection. The -3 that had myopic LASIK, it's well-centered, no complications. I think you can get away with it, and we are. But if they've had a lot of hyperopic LASIK, if they've had RK, if they had a flap lift, anything corneal, you could be in trouble. But it really is about expectations, cautioning them about the one-day post-op, and cautioning them that they're not 30 anymore.
We never like to hear those types of cautions. Steve.
That's it, Paul.
Listen, I still have 30 candles on my birthday cake. I don't know.
Thank you.
We have Botox as a solution for that.
Steve, I know you have to run, and thank you so much for your time. Thank you so much for your time.
Thanks, great audience, great questions. Thanks, guys. Bye, everybody.
See you, Steve. Bye.
Rohit, Dr. Rohit, if you could take that same question from an Indian perspective and just state out, what do you do different?
I think the most important thing is to hit with the right formula. So True K formula is the most appropriate Barrett's True K, which I'm taking into consideration. So that is one thing which, you know, despite everything, so seeing all the formulas which are there, I found that the True K post-refractive seems to be the most accurate one for that matter. The second thing which we have to see is that in this most post-myopic LASIK, you know, whenever it has been done, there is an increase of positive spherical aberration. So the choice of IOL has to be such that it gives the maximum, like the Technis one, which gives the maximum. And for the, you know, the hypermetropic one, hyperopic LASIK, the patients which have undergone, the choice of IOL is such that we go in for like which have a zero aberration one, because that would take care of so many things and not cause other things. So these are some things which we should definitely bear in mind in these patients. And because, you know, we have to be very sure and that in post-refractive, we will not hit, you know, zero. Then how do we do it? Which is the best formula and which, how we, you know, optimize it, that has to be taken into consideration.
Right. Thank you.
Beautiful. Ashvin, do you want to ask panelists any other questions, or I can ask one other question? But
go ahead. It's all yours.
Okay. Whoever wants to answer first, but I guess we've talked about really cool techniques and technologies. I guess going forward for the the next 6 months, next year, what technologies are you most excited, or new techniques are you most excited about? Whoever wants to answer, like what's exciting that you're just starting with or about to start with that you want to share? Neda, you think you're ready to answer.
I already kind of commented on it. I started doing light adjustable lens a bit back, although Robert Maloney has been doing it for a long time now. And I have to say, it was challenging at first. I was a little hesitant. I wasn't quite sure how it's going to fit into my practice. I thought it would potentially sabotage my premium IOL channels, but in fact, it's been an amazing addition. And we have started to fine tune those conversations, and it's fitting just beautifully. And now it's really the first lens that we offer. It's kind of our premium lens, and I much prefer to do the light adjustable lens when possible than toric. The results, I mean, post-RK patients, post-refractive patients, really, I started off with those patients that were difficult ones, and I've been able to hit targets 20/15 uncorrected vision in a post-RK patient. Really amazing results, and highly, highly would recommend it.
That's a great point. I'll just share just briefly that I did get a chance to start with the same technology, and I've been targeting some patients that had some little regular astigmatism where I wouldn't want to use a presbyopic lens. And it's amazing how you can really get their vision quite good with these adjustments. Again, it doesn't correct irregular astigmatism, but just you get at least the spherical and astigmatism component to have some really happy patients overall. No, thank you so much for sharing with that.
Noel?
Yes, I'm going to say that something which I've talked about before, but there's been 2 studies recently that have brought, the independent studies have brought to light, is that I think vector planning, which has been something I've been promoting for, I'll say decades, but it's 2 studies, one by Maria Arbeles published in 2017 in LASIK patients, demonstrated that vector planning patients did better than patients treated by manifest refraction, and they had less refractive cylinder and less corneal astigmatism. And then most recently, just in the process of InPrint, a study out of South Korea by David Kang and his group showed that in SMILE, patients who had vector planning as against compared to the manifest refractive group had less corneal astigmatism, statistically less corneal astigmatism, statistically less refractive cylinder, which is a nice surprise, and statistically less internal aberrations as measured by ORA. So it's really becoming standard of care when you add that to the 2 studies that we've done back in the 2000s. There's now 4 studies which I discussed in the Barricare lecture, which now demonstrate vector planning to be equal to or better than manifest refractive cylinder. I know it was discussed quite a lot in the ASCRS video meeting recently, and it's just becoming popularized, and certainly when this SMILE paper becomes published shortly in JCRS, going to be something which people are going to have to consider seriously as their go-to surgery rather than manifest refraction cylinder. It certainly makes sense to me.
Thank you, Noel. Dr. Namrata?
I think we've been talking about intraocular lenses, and we've been hearing those lenses right since my postgraduate days, when the isomer, it'll change, and those kind of lenses have not yet come in with when you would just change the refractive index of the lens inside the eye, and for any kind of residual astigmatism or residual sphere that remains, you could just do it in vivo, and probably we'll do it on slit lamp. I think that will be the future. I don't know when it is going to come, though. Maybe in our lifetime, maybe not. I understand some clinical trials have taken place, but then it's not really come into the market as such.
Perfect. Thank you. Rohit, yes.
Can I ask Shamie for the light adjustable IOLs, because this is not there in India?
Yeah, it's not come, and we don't know what the results are.
Would you throw some light, not the light which you use for the light adjustable one?
I'm sorry, what was the question?
Just throw some light on the light adjustable, and what are the results been like, and
so I'm sure obviously how the approach is. Essentially it's a 3-piece monofocal lens that is adjustable using a light delivery device in the office that delivers a specific wavelength of UV to the patient. There is some challenges. The surgery is much the same way as any cataract surgery. It's actually much easier because you don't have to consider doing limbal relaxing incisions and other kind of thoughts around formulas and such. So you implant the lens. You tell the patient they have to wear UV UV blocking glasses at all waking hours, and then we are now doing this second eye with less than a week apart, and then at about 2 weeks mark, where the refraction starts stabilizing, the patient then can have light adjustments in the office, and the light adjustments can be done up to about 2 diopters of sphere or cylinder in any direction, and we've learned some lessons in the beginning. Your goal is not to get the patient anotropic right after the surgery, because then it's hard to make them happy. So we're actually now targeting a little bit of hyperopic refractive outcome so that there's a little bit of a wow effect. So one of the challenges is that the wow effect is delayed, but the wow effect is a bigger wow effect. And so typically it's taken about 3 light adjustments. So the patient comes in every about 3 to 4 days after that first light adjustment at 2 weeks mark. What happens at the 2-week mark, though, is when we do our refraction and see what the residual refractive error is. And also that's when we do target planning. So what happens, the whole discussion about refractive outcome and target planning gets shifted to post-op, when it's a lot easier to demonstrate to the patient what monovision is, because the vision now is corrected, there's no cataract, and you can do contact lens trial for the patient, and you can start having that discussion when the vision is correctable to 20/20. And then you do the light adjustments, about 3 adjustments, as I said, 3 days apart, and then you lock it in. I have to say it's been a little more unpredictable than I like it to be, where you plug in the refraction, you plug in what your target is, and you expect, like LASIK, we're all LASIK surgeons, we expect, okay, that's going to give us emmetropia, or it's going to get us where we want to go. It doesn't always behave that way, and I think that's where the data is going to help us. There's probably some variations based on corneal curvature and how the light passes through the cornea. It's also difficult because the patient fixation is limited. It's hard for them to look towards a bright light and keep their fixation. So if there could be light treatments that would follow the pupil, for example, or the visual axis like we do with iris registration and such. So there's still a lot to be learned, but I have to say the initial results have been really, really impressive.
Yeah, I would agree that with Neda, it's been super exciting. You don't always get the perfect result on the first treatment, but usually by the second treatment, we're really close, if not perfect. And then I do agree with Neda that, like any new technology, this will continue to evolve and even get better and better. I think that's why the release is relatively slow in the United States. They're releasing it, step by step with a lot of careful work with each doctor that's getting the technology to make sure that they troubleshoot everything and try to keep adapting. So it'll be available everywhere, in the not too distant future, I'm sure.
All right. I think we probably need to close this session now, but thank you, everybody, attendees from all around the world. I think there've been so many from Gulf, US, Brazil, Myanmar. I'm not sure now. I couldn't count the number of countries now, but thank you so much for being a part of this. Noel, Namrata, Bill, Neda, Rohit, sir, thank you so much for being a part of this. It's been such a joyride to even work with you guys, especially on a podium, but right now this is our new podium. This is our new platform for some time at least. So for the foreseeable future, I really hope to see you guys in person, live in the flesh very soon. But till then, sayonara, good night, and good morning for everybody from Neda's side.
And thank you, Ashvin, and thank you, Bill, for the invitation and the opportunity to participate, and hope to see you soon.
And thank you, IRSI. Thank you, Alcon, as well, I must say. Thank you so much, guys.
Thank you.
Bye-bye.
Bye, guys.